So I feel like, we're close neighbors, but I think the virtual conference is what we've settled on at NYU as well to increase, people showing up. But it is nice to see you all. So we'll get started so we have some time for Q&A at the end. I have no financial disclosures. We're going to talk about the evolution of POCUS in medicine, how it's grown to where it is and why, with some of the supporting evidence. We're going to talk about POCUS in medical education at large, but also specifically at NYU, some of the scholarship that we've been doing in POCUS, and future directions. So first, we'll start with a definition of what POCUS is. I'm not really sure with this audience, how experienced you all are with this, but POCUS is defined as a goal-directed ultrasound examination performed by a healthcare provider to answer a specific diagnostic question or guide performance of an invasive procedure at the bedside. Just to break this down briefly, goal-directed means you're answering a specific question. You're going to the bedside saying, does this patient have a pleural effusion? As opposed to when you order an abdominal ultrasound, the technician just does everything, not really with a clinical question in mind. And as far as a healthcare provider, that could be a doctor, that could be a nurse practitioner, that could be a nurse, a PA. It's really a wide open field. And we're going to talk a little bit about its use in invasive procedures later. So this is one of the early uses back in 1946. This is certainly a long ways away from a point of care, but this you can see the patient entering this contraption from the left side of the screen, and the physician here in the white coat on the right. And then we've come a long way. So this is one of the more current ultra portable handheld models. You can see what this does. This brings the provider in direct contact with their patient. And here you can see, you can use your own tablet, you can use your own cell phone. The technology has really advanced quite remarkably. So I'll start with a case. This was a rapid response at Bellevue Hospital that I responded to with the team on the psychiatry ward. We encountered an older man, obese. He was sitting in a chair. This is an artist rendition. We did not have a photograph. So this was, he was presenting with acute dyspnea, but given his psychiatric condition, he was really not able to provide much of a history for us. So we weren't able to elucidate much further than that in our bedside evaluation. So we had the typical differential diagnosis: pneumonia, heart failure, pulmonary embolism, anemia, the usual suspects. So we had the ultrasound with us. So we just started to take a look to see what there might be to see without anything really, honestly, specifically in mind. And over his abdomen, we found this large cystic structure. So I'll try to orient everybody here, given that I'm not sure how advanced you are with your kind of understanding of ultrasound. So this would be an axial view, similar to how a CT would be interpreted. So the left side of the screen here is the right side of the patient. And so this is the left side of the patient. This is the near field, and then this is depth. You can see the depth here counter of 21 centimeters. And you can see here we have a large fluid-filled cystic structure that measures here to 17.5 by 17.2 centimeters. And then we started to localize this essentially over the lower midline abdomen. So now we turn the probe 90 degrees. So we now have a sagittal view. So the left side of the screen now represents towards the patient's head, and the right side of the screen represents towards the patient's feet. And again, this is still the near field, and this is still the far field. And this measurement, again, the cystic structure exceeds the limits of this field, but measured at about 25 centimeters. So we presume that this was most likely the bladder. We can estimate the volume of the bladder pretty easily at the bedside. Just length times width times height. And since it's not a perfect cube, we multiply by a correction factor, typically by about 2/3. So in this case, 25 centimeters by 17 by 17 by the correction factor of 2/3 gives us an estimated bladder volume of about 4.7 liters. So this is the measurement we actually got at the bedside. I was incredulous that this could actually be the case, but we did put a Foley in him, and we drained 4.5 liters. Pretty remarkable. And so what we found, my conclusion from this case was pretty remarkable. He was a guy who was acutely dyspneic on the psychiatry service with a broad differential diagnosis. Without POCUS, he would have been, admitted to medicine. We would have gotten a CT study, echocardiogram, full set of labs, the whole thing, and we still wouldn't have gotten to the right diagnosis. In this case, we were able to figure out immediately what was going on with him. We put in a Foley, drained him. He immediately got better. He was a psychiatry patient, so he was on Clozaril amongst a bunch of other meds that would cause urinary retention. And so then they were able to manage him on the psychiatry unit. So speaking of the evolution of ultrasound, there haven't been a lot of technological advances for our bedside evaluation over time, right? We had the stethoscope a couple hundred years ago, x-rays, tuning forks and things like that. But as far as being able to make a diagnosis at the bedside, ultrasound really has been the major recent advancement. So in evolution in medicine, the first academic course on cardiac ultrasound, the first echo textbook, even the term echocardiography, these were all developed and coined around the 1960s and 1970s. So emergency medicine picked this up pretty quickly in the 1990s. Back then they were doing a lot of traumas and knew the strength of ultrasound. And so they would go to the radiology suite, grab the ultrasound machine there, liberate it, take it to the emergency room and do some of the early fast exams there. And so the ACGME has made POCUS a training requirement for emergency medicine since 2012. Ultrasound guidance has become the accepted standard of care for a lot of procedures that we do in medicine, central lines, paras, thoras. This is all really a standard of care to use ultrasound now. So just a quick word on likelihood ratios, since this is a medical education grand round, I'm presuming that you guys have some comfort with this. But just to say briefly, it includes sensitivity and specificity meant to change your post-test probability. So likelihood ratio of 1 doesn't change it at all. And likelihood ratios of 2, 5, and 10 will increase your post-test probability, and 0.5, 0.2, and 0.1 will decrease it. This correlates then to post-test probability changes of 15, 30, and 45%. And then you can see the negative values. So clinically, we like likelihood ratios of 5 and 0.2 as a start, but we really like likelihood ratios of 10 and 0.1 to really help to rule in and rule out disease. So let's just start with something that we all can understand. These are different applications that we could use point of care ultrasound for and how it compares potentially to a physical exam. So looking for LV function, you can see POCUS is not the best tool for it compared to a laboratory echocardiogram. But even with basics that a primary care doc, internist could do, you can see here we can actually evaluate LV function the way you can't do with physical exam. Pleural effusion, ascites, any times where the question is there fluid, yes or no, it's a very powerful tool. We can evaluate for DVTs. You can see the likelihood ratios here are very impressive. For looking for hydronephrosis, again, impossible to do with physical exam, but a very common question, outpatient and inpatient. We can use point of care ultrasound. And then just to run through, we can evaluate the bladder, we can look for abscesses, AAAs for screening, or for abdominal catastrophe, pericardial fusions, using during rescue, ACLS, and again, standard of care for procedure. So we're using point of care ultrasound for a lot. This is not even a fully comprehensive list. So for the example of pleural effusion, specifically for those of you who still are using physical exam, and I hope there are a lot of you, the two common techniques we use are percussion dullness and listening for decreased breath sounds. This evidence comes from McGee's evidence-based physical diagnosis. And you can see here, these are pretty reasonable likelihood ratios of about 5 to help rule in pleural effusion if they're present. And 0.1 is quite powerful if those are absent. But of course, this is all dependent on your skill as an observer, the environment you're in, the patient's body habitus, et cetera. And you can see here outlined the likelihood ratios, positive and negative. But if you're looking at point of care ultrasound for pleural effusion, you can see the positive likelihood ratio here of 47 and 0.06 is just like on another level. And it's a very easy application for beginners coming right out of a course. This is something that really anybody could do in that setting. And you can see the likelihood ratios here outlined on this linear graph are quite powerful. So a quick overview of lung ultrasound for volume status. This is what a lot of this talk is going to talk about. So lung ultrasound really shouldn't be a thing. You can't like go to the radiology part of Epic and order a lung ultrasound. It doesn't really make sense, but we use it because the lung is filled with air normally. And therefore, you can't evaluate it because all you get are artifacts. And that's what we're seeing on the far left here, is just a pattern of artifacts. And just to orient you again, typically when we hold the probe for lung, the head, the left side of the screen is oriented towards the patient's head, and the right side of the screen is oriented towards the patient's feet. This is skin and soft tissue. This is the pleura. And the sound waves just bounce back and forth and give you a series of artifacts. So everything below the pleura is pure artifact. But as the lung goes into abnormal states and fills with fluid, then the sound waves have something to bounce off of, and it actually creates a series of artifacts that we call here B lines. So you can see here, these are these laser-like projections coming off the pleural surface. And if you see those, that implies some interstitial process such as fluid, or perhaps even pneumonia or atelectasis. As the pathology becomes more severe, you actually develop a tissue-like structure under the pleura. And what we say, like the wettest abnormality here is a pleural effusion, which again is a very obvious finding on ultrasound. So we have protocols to evaluate for pulmonary edema and to assess volume status. A lot of this comes out of Europe and in France and Italy, where they used actually more zones than this. But this has become more and more standard practice. So we would use an 8-zone method. We would put the ultrasound probe in these 4 spaces in each hemithorax, so 4 on each side for a total of 8. And you would just count the B lines over those 8 zones. It's actually not so different than auscultating somebody in those zones and listening for crackles. In this case, the patient can be fully recumbent or semi-recumbent. They don't have to cooperate with the breathing. You don't have to listen or go over their back. So it's actually a very approachable evaluation. And then we'd also be looking for pleural effusions as we do this. So this doesn't take very much time or very much skill to do this. So just to compare how lung ultrasound evaluation would compare to some of our other standard techniques. So this is comparing lung ultrasound to chest X-ray for the evaluation and detection of pulmonary edema and heart failure. You can see similar specificity at 0.9, but lung ultrasound exceeds chest X-ray with a sensitivity of 0.88 compared to 0.73. So better chest X-ray as evaluating for pulmonary edema. This is an evaluation, a single center study done out of Japan and a heart failure unit there. These are patients referred by their primary attending for right heart cath because they had some questions about their volume status. So they did an 8-zone protocol, right, looking for B lines. They looked at populations of patients with preserved EF and with reduced EF. And they looked at 2 things. They looked at hemodynamics. They wanted to compare the number of B lines to the invasively measured wedge pressure here, and they also looked at prognosis. So when looking at the invasively measured wedge pressures, if you had 6 B lines or more, that showed that the wedge pressure was abnormal at that point, right? For both HEF-PEF and for HEF-REF, you can see 6 B lines signaled a level at which the wedge pressure was elevated. And then when looking at prognosis, they evaluated these patients for cardiac death or rehospitalization at 1 year. And what they found that the presence of 6 B lines, meaning residual congestion, did increase the probability of this outcome at 1 year. So pretty powerful just to look at 8 zones and to be able to correlate that to a wedge pressure and to 1 year outcomes. So this was a systematic review looking at 2 patient populations. This is acute heart failure, so admitted pre-discharge patients where an abnormal lung ultrasound pattern predicted heart failure, hospitalization, and death. And then this lower row is for chronic heart failure, so in the ambulatory setting where abnormal lung ultrasound also predicted that same outcome. So this was another single center study out of a heart failure unit in Spain. And so what this study was looking at compared to the others is they wanted to see if telling the providers to use lung ultrasound to guide diuretic therapy, right? So we haven't seen lung ultrasound used outside of just a prognosis study yet. So what they did, at hospital discharge, they did a baseline visit. They looked at an N-terminal proBNP. They did a lung ultrasound, a 6-minute walk test, and a quality of life score. Then after discharge, they looked at the patient in the ambulatory setting at 2 weeks, 1 month, 3 months, and 6 months using a proBNP and a lung ultrasound. And at the final visit, they also did the walk test again and the quality of life score. And so what they found here, and I'll just walk you through this briefly, the primary endpoint, they said, was improved in the lung ultrasound group with 40% compared to 23% meeting this primary endpoint. And this was driven by the individual outcomes of, urgent visits, heart failure, hospitalization, and death. And you can see this was driven by urgent visits for worsening heart failure. They didn't tell the doctors what to do. They just said, use lung ultrasound to guide diuretic therapy. There wasn't much difference in the internal proBNP group. There was maybe a slight trend towards favoring the lung ultrasound group, but it was not statistically significant. So the conclusion of that last study was that heart failure patients randomized to lung ultrasound guided diuretic therapy had fewer heart failure decompensations and improved walking capacity. So the ACC and the ESC both, I would say, allow for the use of POCUS in the evaluation and treatment of heart failure patients. I would say they're certainly not suggesting it to be standard of care just yet, but they're certainly advocating for its use. The ACP did a review of patients with dyspnea, and they also suggested that in patients where there was diagnostic uncertainty in patients with acute dyspnea, that POCUS could add benefit. And as far as procedural success, I'm not going to get into a lot of the data for this, but just to say there's been a lot of studies that POCUS increases the success rate, decreases the number of pass attempts, decreases the amount of time to successful procedure, decreases the complication rate for pretty much any procedure you can imagine, central lines, peripheral lines, even lumbar punctures. It's typically used for landmarking and also for paracentesis. But pretty much arthrocentesis, you name the procedure, ultrasound will often guide that procedure. As far as hospital metrics, heart failure patients managed with lung ultrasound had shorter lengths of stay than patients managed with usual care in one study. And then as far as patients on a medical procedure service, those who got a bedside paracentesis had a shorter length of stay compared to those patients referred to interventional radiology by almost 2 days. And we've seen this in a number of studies. This was a study out of Northwell looking at their MICU at North Shore versus their MICU at Long Island Jewish. At Long Island Jewish, they use POCUS not just for procedures, but also for diagnostics. And they found that without compromising quality, that at Long Island Jewish, that use of POCUS decreased the use of chest radiographs, chest CTs, abdominal and pelvis CTs, radiology service performed DVTs, and cardiology service performed TTEs. So using it in a MICU decreased resource utilization without compromising care. As far as patient experience, I can tell you personally that patients really like when the doctor and with the team is using POCUS, especially from a team like bedside rounding perspective. They're really engaged in the process. They ask a lot of questions. I found it really useful. And here's a couple studies that back that up as well. The first one is from an ER setting. And the second one is from an inpatient setting where they were specifically looking at shared diagnostic understanding between patients and providers. And then there's just a number of publications and governing bodies that have been advocating for the ongoing use and spread of point-of-care ultrasound. All right, so point-of-care ultrasound in medical education. So this picture is from a point-of-care ultrasound competition. It's called the POCUS Olympics that was held in Hofstra. This was in February of 2024, but they held it again in 2025. You can see there's just a lot of engagement in this. Our students went went in on a Saturday, spent the day there, really had a great time. But just to say that there are increasing numbers of medical schools that are teaching POCUS formally. POCUS can be used to enhance teaching of anatomy, physiology, physical exam, and procedures in medical education, both for UME and for GME and for CME, I would say as well. There's many ways that this could be done. Typically, most of my career, I finished in 2005 residency, and I didn't even start my first POCUS course until 2018. So most of my career was in teaching physical examination at the bedside, and a lot of that was teaching the JVP exam. And so now what I do is I'll do a visual JVP, walk everybody through the formal way of doing it, and then we can put the ultrasound probe on and actually like show them the level of the JVP. So it's a really powerful way of doing it. So this picture, just to kind of orient everybody again, this is an axial view over the patient's neck, where we see the common carotid artery and we see the internal jugular vein. And as you slide the probe up the neck towards the mandible, at some point the jugular vein will collapse. And then that's the point at which you would say that's the level of the JVP. So from a GME perspective, they're also increasing reporting of POCUS training, specifically in the GME setting. Graduates expect continued opportunities to learn and advance their POCUS skills in residency. Specifically, these studies have been done in pediatrics, internal medicine, and family medicine now. The ACGME has requirements for teaching POCUS. So this was a recent study from JGME, just to kind of put your focus to this cell A and cell B. So the blue and the yellow are those kind of trainees who are thinking about a hospital medicine job or not. So no in blue and yes in yellow. And this is their confidence for learners in these different areas. And so you can see their confidence in POCUS is not high, right? But if you look at the cell B, it says desire for more teaching for learners, and that they want to learn more procedures, they want to learn more POCUS. And as far as what does the ACGME say about POCUS for internal medicine, is that residents must demonstrate the ability to use and or perform point-of-care lab, diagnostic, or imaging studies relevant to the care of the patient. They specifically comment that POCUS is something that they could learn to satisfy this, but they want to allow each learner the opportunity to focus on areas of their choosing. This is a evaluation of program directors regarding POCUS programs. So this is blue is they don't have a POCUS program, and orange is that they do have a POCUS program. And so the barriers here are not enough faculty, not having a POCUS champion. Having resident interest was not a barrier. And as far as logistics, having ultrasound machines was a barrier, and supportive faculty time was a barrier. But again, being an educational priority was not considered to be a barrier. All right, and so what are we doing at NYU? So from a UME perspective, there is a UME POCUS director. This has typically been somebody from the emergency department. They arrange a few workshops for the students. As you know, we've moved to a 3-year program, so it's a very condensed curriculum that they get. But it's about 6 hours of POCUS education in this preclinical time that's comprised of a series of workshops. From the clinical years in the UME perspective, they are also, all the students on clerkship on medicine are supposed to get 3 hours of supervised scanning, depending whether they're at Tisch Kimmel, at Bellevue, or at the VA. They're supposed to get teaching at each of those sites by one of our faculty, and this is arranged by one of our hospitalists, Aaron Mednick. Outside of internal medicine, the POCUS curriculum is just implicit, whether they're in pediatrics where they may get it, obstetrics where they may get it. It really depends on just what they're exposed to in those rotations. We also have an internal medicine POCUS elective that I run. It's 2 students every 2 weeks. I really run it most of the year, and it's been a very popular elective. EM also has a POCUS elective. There is a POCUS interest group. I had mentioned that we had gone to Hofstra for this POCUS Olympics. So here's our, 3 of our students who are participating. This was afterwards, we had sent 3 teams there actually. So there was 9 or 10 students there. And we had done very well at this. We had, come in 1st and 3rd place. Historically, there's always been a national competition for the medical students called Sono Slam at the American Institute of Ultrasound and Medicine. For some reason, this last year they didn't hold it, but this is from the 2024 where we sent a team. This was in Austin, Texas, and we had a really great time. So from a GME perspective, we have a GME lead, Caroline Strisar-Jivakol-Klein. And so since 2019, all of our residents go through a formal POCUS training that we based on the chest course. Our mentor for this, Harold Sautoff, is one of the national chest leads. He's a pulmonary critical care attending. He's now at Westchester Medical Center. But our course is based off the chest course. So they do this over their +2 time. And then there's a longitudinal curriculum. There's even recently a POCUS track that 2 students are allowed to do each year. This is in a trial period, and we're going to grow this. There's also a resident POCUS elective, and the residents also learn knee ultrasound during their ambulatory rotations. We run a CME course in partnership with Northwell. We have teachers that come. They're nationally recognized teachers. So these are teachers from, Minnesota and Johns Hopkins and North Carolina. So they're from all over the country, and we run this twice a year. I think we've definitely taken. I think we've taken Sinai residents as well there. And so we run about 30 people per course twice a year, alternating between Northwell site and NYU. We run our own internal course that we've had a grant that helps fund, time for the standardized patients and to provide lunch for the learners. But we run this about once a year now, and it's 30 to 40 learners. There's PAs, NPs, doctors from around Bellevue, VA, NYU, and some of the other NYU hospitals. People are really having a great time. We get our own teachers as they're improving to actually teach at these courses. And this picture on the right, Jen Dong is doing a scholarship. We call it a Marin Fellowship in POCUS for the outpatient setting. And here she's teaching 3 of her colleagues who work at Bellevue and the VA. Some testimonials. This is from faculty learners from the course. So by far one of the most helpful and rewarding postgraduate and Sim Center sessions I've participated in. I'll now look back on this class as a defining moment in my medical career. Practice-changing experience. Thank you, Harold and Mike. And then excellent course should be required for all med students, residents, and attendings. And I like to think there's a little bit of foreshadowing in that last comment. So this is the impact from our different programs at NYU. So this course that we run yearly, we've run since 2018. I'm counting in 2025 where we just had our January course. So a total of 281 faculty and other learners. The resident course, it's pretty much 55 residents per year. And our CME course, besides the year that we had to stop for COVID, we've put through 60 per year. And for 2025, we plan on 60 for this year as well. It's not just internists that have gone through this course. We've put through cardiologists, infectious disease docs, GI, nephrology, oncology, neurosurgery, neurocritical care. So there's a lot of interest, even outside of medicine, for this. So the equipment that we're using here, so we initially started with a philanthropic grant, which allowed us to buy about 18 of these butterfly devices just to get people started on it. And so we sent these out to all the teaching teams at our different hospital sites. But then we were able to get traditional cart-based machines. So at health and hospitals, we invested in these GE machines. The VA also has GE machines. NYU has Philips machines. And so our medicine service has about 3 or 4 of these at Bellevue for about 300, 350 patients. And so these are wired to, it's called QPath. It's a software where you can upload clips to, and then they can link to the medical record if you so desire, or you can just use it for education. So we have a certification and credentialing system, both at NYU and at Bellevue. So, and really across all of health and hospitals. So NYU specifically requires a focused, limited portfolio. It's kind of like a la carte. If you just want to do lung, you can just do lung. Health and hospitals, I helped to create this credentialing pathway. So I figured, like, we're internists, we don't just focus on one system. So you're either all in or not. And so you have to take a 2-day course, and then you have to finish this comprehensive portfolio of good quality images for all the systems that we cover. That's based on the SHM and CHEST certificate of completion pathway. And then as people get credentialed, we can review their uploaded clips for quality. So a couple of the papers that our group has put out. So this was the first one. We're going to start with the resident OSCE, and I'm going to go through these somewhat quickly just so we have time for Q&A at the end. But this was after the residents have gone through the training, then subsequently they have an OSCE that's part of their kind of general training OSCE. And so we've put it through 35 of our PGY2 residents. And what we wanted to question was, not so much can they just do look at the kidney, can they just look at the heart? We wanted to know how they're incorporating it into their clinical care. And so we figured the OSCE was the best way to evaluate for that. So we start with a case vignette. In this case, it's a patient with lupus who presents with dyspnea and fever. And then we just have a healthy standardized patient model there. And we say basically like, scan this model the way you would scan an actual patient. And then depending on where on the model that they scan on a PowerPoint slide, we show them images from the actual patient. And then they're able to interpret those abnormal clips and then come up with a differential diagnosis. So some of our conclusions from this, or what we found from this, was that the learners looked at the lungs, but they didn't look at them comprehensively. They mostly just looked at the apex of the lung. Some of them didn't look at the lateral areas of the lung, which is a really important area to look at with ultrasound. They didn't look at the left base, 17%, 28% didn't look at the right base. Again, these are all really important areas to look at when you're doing lung ultrasound. And only 38% completed what we consider to be a full lung exam. Again, this may be an OSCE effect of them not knowing exactly like what they were expected to do, but we certainly were expecting more of them. Okay, so what diagnoses did they generate from this? So 5 of the diagnoses were supported by the imaging. So pneumonia, pneumonic effusion, empyema, volume overload, and serositis. But they also came up with diagnoses that were not supported by imaging, such as pneumothorax, asthma, tamponade. We figure, again, this was more OSCE effect. They were reading the case prompt and just thinking of things that the patient might have, even if it wasn't like related to what they actually saw. So our conclusions from this OSCE study was that residents know what ultrasound exam is appropriate for a particular scenario, but they were variable in their ability to follow through and actually acquire appropriate images. When confronted with abnormal clips, most could contextualize the images in the case and come up with a reasonable differential diagnosis and come up with a subsequent reasonable management plan. So what our conclusions were from this is that we really needed to improve our curriculum to fill gaps in resident knowledge and support the resident hands-on practice. And so what this means is doing more case-based teaching. Even when we have healthy models, we would say, all right, pretend this model has, like we're suspicious for a pneumothorax. How would you evaluate this patient? You're worried that this healthy model might have pulmonary edema. How would you evaluate? So we're really trying to get them, even with a healthy model, to use the mindset of approaching them as if they were, a patient. So moving forward, this was our evaluation of our initial cohort. This is the one that actually I was a learner in. And so this was and took place in 2018. And this is essentially how our course continues to this day as well. So there's a period of self-study where we ask people to review content that we've uploaded to our educational platform called Brightspace. And they're supposed to do this in advance. Then they take the 2-day course. There's some assessments that we do before and after. And then immediately after the 2-day course, we expect them to participate in this longitudinal curriculum that includes independent scanning, to upload clips, to attend monthly conferences, and to participate in hands-on teaching sessions with an expert. And then we repeat the assessments. So here's what we found, and I'll walk you through this. So the first 2 rows are the pre-2-day course and immediately post-2-day course. And of course, these are like the obvious results that if you give somebody, education and you immediately test them, that their, scores on their test and their confidence will improve. That was not surprising. So these next 3 rows are the more interesting. So we repeat here the post-2-day median. So now our baseline is immediately after the course, and our assessment is 1 year later, right? So post-course to 1 year later. The knowledge test, right? This is an online administered test. They went from 85% to 81%, which was statistically significant, but I would say not educationally or clinically meaningful. They started off at a 58% score, and even a year later, they ended up at 81. So that was a success for us. Confidence a year later was not statistically significant, and neither was the result on a hands-on test. And so we wanted to find correlates to success, right? And we considered success to be doing well on the hands-on test. And so what we found was, if you look at these correlation coefficients here, the 0.85 is the highest, and that is with clip uploading. So for those who uploaded clips, they did better on their hands-on test. The next highest correlation was 1-year knowledge at 0.78. So our conclusions from this 1 year, this first cohort was that both the 2-day course and the longitudinal curriculum are effective. Clip uploading is associated with success, and that the knowledge test itself is an effective assessment tool. During COVID, we had to adapt, as did everybody else, and so we made some of it hybrid. And the short story here is what we found is that learners did just as well with the hybrid program as they did with the traditional, and so we felt comfortable taking the best of both curricula into our current. And so our most recent evaluation was the long-term follow-up. So we've been doing this course pretty much yearly since 2018. We had 89 faculty graduates, and we surveyed them and gave them the knowledge test again. And we'll go through this quickly again, just so we have time for some Q&A. So we had a 52% response rate. And so this first figure is how confident are you in your ability to acquire and interpret these views? So heart, lung, abdominal organs, deep veins, and knees. So there was all a reasonable amount of confidence. The lungs is the easiest, and that is what they were most confident in. We didn't actually teach the knee most of the time, but because we do a lot of primary care teaching, we have included it, and not surprisingly, they were not so confident with that. This question is, how likely are you to use ultrasound to evaluate the following? Ascites was the most common, probably because we're looking for paracentesis, but dyspnea, volume status, acute kidney injury, these are all very common. And you can see they're using ultrasound for a wide range of clinical questions. This is a little busy, but just to show you that we wanted to know, again, like what were the correlates of success here? And so what we wanted to find was portfolio completion, because we did ask people to do a portfolio. So if they did this quite labor-intensive image portfolio, their score on the knowledge test was 92% compared to 68% for those who didn't do a portfolio. We then stratified by whether they did the course, in 2018 to 2019 or later, and there was not a statistically significant difference. We also wanted to do the question of, well, maybe they didn't do the portfolio, but are they using POCUS? And those who say they use POCUS for dyspnea did do better than those who don't, right? 78% compared to 65%, but it was a much more dramatic split if they had done their portfolio. So we found here the portfolio was a better measure of competency. This is heat map looking at confidence. So those who did the portfolio were more confident, really specifically for lungs and abdomen, but you can see there's a pretty dramatic difference there. And so faculty who are using POCUS for a wide range of indications, and that portfolio completion correlates with knowledge and confidence. So we're going to wrap up here. Future directions, we've been continuing to do projects and research projects. So we have a street homeless program where we have vans, where we bought ultrasound machines for the vans, and we're trying to, we've taught all of the faculty the 2-day course. So now our challenge is to get them to get credentialed and to actually start using it, but they have access to QPath and to upload into Epic. And so we're going to work on getting this group up to speed. We're going to continue to try to push POCUS into the outpatient realms, but there's a lot of barriers to that, as I'm sure everybody on this call will acknowledge. And we're trying to work across divisions and departments to study different patient populations. We want to do better with our resident competency. What does it mean for a resident to do a track? What does it mean for a resident to be competent in POCUS? So we're looking into those questions as well. And we're anticipating a time where ACGME will require POCUS for internal medicine. And we want to be prepared for that. So we'll finish with some acknowledgements. This is Harold Saltoff, my mentor for POCUS. We meet weekly with a group where we talk about our projects and research projects. As I mentioned, we had some philanthropic funding to help support our program. Deb Cook is our program manager, and definitely we need her to help make this program run. And Sandy Zabar is our division director and has been very supportive of this program, and we owe a lot to Sandy. And I will wrap it up there.